Mr. President, we now have a draft of the Senate leadership majority's health care reform bill. After spending several weeks behind closed doors producing that bill, at least some of the details are starting to emerge, and I think it's really critical that all members here in the United States Senate have an opportunity to look very closely at what's in that bill. It should come as no surprise that it is a 2,000-plus page bill. Much was made of the House of Representatives bill being a 2,200-page bill when it was all said and done. This is 2,074 pages long, which hasn't been amended yet. Obviously, that probably will grow and expand as this bill comes to the floor. But I think we at least now have something that we can look at, something that we can review. And there was a lot made last night by the majority as they went out and unrolled this bill, at how fiscally responsible this particular proposal is, and how much of an improvement it is over recent drafts of this legislation. But I want to point out a couple of things to my colleagues that I think perhaps puts into perspective what this bill would really do, what it entails, and how, with all the rhetoric about how it differs or improves upon previous versions or previous drafts of this bill, really comes down to the basic same elements that have been in all the bills that we've seen so far. And the first point I want to make is with respect to the cost, because it's very clear that the cost of this bill, which was stated last night as $849 billion, is dramatically understated relative to its true cost when it's fully implemented. And the reason for that, there are several actually reasons for that. One is that they push back the effective date, the implementation date, for many of these provisions to take effect to 2014. And so you won't see the actual spending in this bill start to kick in until January 1 of 2014. However, Mr. President, many of the revenue components in this bill begin to kick in next year on January 1st of 2010. And so the tax increases, which are multiple, and which are hundreds of billions of dollars, would begin to take effect immediately starting January 1st of 2010, while much of the spending in the bill would be deferred until much later in the budget window, not taking effect until January 1st in the year 2014. And so that distorts the true picture of what this legislation would cost and distorts it substantially. The other point I'll make is there are a couple of other provisions in the bill which, by their absence in one case and by their inclusion in the other, understate the cost of this bill. One is the absence of the sustainable growth rate formula, or the so-called physician fee fix, the reimbursement formula by which physicians are reimbursed, not being addressed in this bill. That's a $247 billion hole, $247 billion additional spending that's not included in this bill. So that obviously understates the overall cost of this. And there's also a $72 billion assumption in there for a program called the Class Act. Now, I want to read for you something that one of my colleagues on the Democrats' side said about the Class Act. Now, this was the senator from North Dakota who's the chairman of the Budget Committee here in the Senate, called the Class Act a Ponzi scheme of the first order, the kind of thing that Bernie Madoff would be proud of. That's how he refers to this Class Act that's included in the bill and the savings that are associated with it. And in fact, the $72 billion that it shows as revenue in the first 10 years turns into a deficit in the second 10 years. And so when you back out the $72 billion that is assumed would add to the revenues in this bill, and you add to the cost of this bill the $247 billion that would be required to fund the physician fee formula over a 10-year period, the so-called surplus that this bill generates actually turns into a deficit. It goes from a surplus of $130 billion to a deficit of $189 billion. So, again, a lot of gimmicks being used here to understate the true cost of this bill to the American people. But all that being said, if you look at the overall cost when it's fully implemented over 10 years, here's what you come up with. Now remember, when the Senate Health, Education, Labor, and Pensions Committee passed its version of this bill out of the committee, the 10-year fully implemented cost for that bill was $2.2 trillion. When the Senate Finance Committee passed its version of the health care reform bill out of the committee, the 10-year fully implemented cost of that bill was $1.8 trillion. So $1.8 trillion for the Finance Committee bill, $2.2 trillion for the Health, Education, Labor, and Pensions Committee bill. Guess what the price tag is on the bill that was merged together and has now been unveiled for all the world to see? $2.5 trillion. Overall cost, 10-year fully implemented cost. A $2.5 trillion expansion of the federal government here in Washington, D.C. associated with the fully implemented cost of this bill. And so, Mr. President, my point very simply, the point I'm trying to make is this. The cost of this bill is being dramatically understated by the authors of the bill to make it look like it comes in under $1 trillion, when in fact, when you back out the two components that I just mentioned, it's over $1 trillion in the first 10 years, and that's because they delay, again, the implementation of many of these provisions until January 1 of 2014, a budgetary gimmick that's designed to understate the true cost of this bill. But when you look at the fully implemented 10-year cost of this legislation, without the gimmick of the delayed implementation date and the other gimmicks that they included in here, $2.5 trillion in additional cost to the taxpayers of this country. Now, of course, that $2.5 trillion has to be paid for somehow. And the way that it's paid for isn't any different than in any of the other bills that we've seen so far. It's paid for with higher taxes on small businesses and higher taxes on individuals, and it's paid for in cuts to Medicare programs that would impact senior citizens around this country, as well as medical providers, from hospitals to home health agencies to hospice, you name it. You go right down the list. Medical manufacturer or medical device manufacturers get hit pretty hard in this legislation. Everybody gets hit when it comes to the reimbursement side to pay for this, and of course the American taxpayer gets hit hard when it comes to the tax increases that are included in there. $500 billion in tax increases, $500 billion in Medicare cuts to finance this $2.5 trillion expansion of the federal government to create a new entitlement program. Now, the other thing this bill does, which wasn't included in any previous version, is it does have an increase in the payroll tax on Medicare. Now, the argument that's being made is that it only applies to people in the higher income categories. And in fact, they did try to carve out people under $200,000 a year. But remember, the Medicare tax, the payroll tax that every employee in this country pays, which is 1.45% on their income, matched by their employer for a total of 2.9%, it gets increased. And so it gets increased to pay for not reforming or making Medicare more sustainable, a program that we all know is destined to be bankrupt by the year 2017. The increase in the Medicare tax will fund a whole new entitlement program unrelated to Medicare. Now, the argument will be, well, it's a health care program. But the fact of the matter is the Medicare payroll tax was put in place to fund Medicare, a program that people would pay into, and so that when they retire, they would have the security of health care coverage. Well, Mr. President, the payroll tax that's included in this is going to go directly. First off, it's going to hit a lot of people in this country, and if you're a couple that both make a couple hundred or $100,000 a year, you're making $100,000 a year each, you're already into the category where you're going to be hit by the tax. But one of my main objections, I mean, I'm not for this tax increase in the first place, but one of my main objections is that the majority has chosen to use that tax increase not to make Medicare more sustainable, but to create a whole new entitlement program with this bill. Now, the other thing I want to point out, because it's come up here just in the last day or two, but, you know, there's been all this discussion about mammograms. This Preventative Service Task Force came out with a recommendation that women under 40 shouldn't go through mammogram screening, which, of course, a few years ago, they made the opposite recommendation. Going back to 2002, the U.S. Preventative Services Task Force made the recommendation that women 40 and older undergo annual mammograms to check for breast cancer. Now, that recommendation was completely reversed earlier this week. The 16-member task force ruled that patients under 50 or over 75 without special risk factors no longer need screening. And of course, what's being said about that, and they're backing away from that in a hurry. The Secretary of Health and Human Services, Kathleen Sebelius, came out and said, no, 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 that's not, you don't have, nothing's going to change. This is just a recommendation, it's not binding. Well, that may be true today, but here's the problem with government-run health care. Here's the problem with the direction that we're heading with this legislation. With a greater level of government involvement and government intervention, and more requirements imposed on those who offer insurance products, particularly those who contract with the government, I think it's safe to assume that many of the new creations in this legislation, and there is a new Medicare Advisory Board, will have recommendations that are not just recommendations and advisory, but in fact binding. And this is exactly the point many of my colleagues have been making about government-run health care, is that when you start down that path, and we've seen the model in places like Europe and Canada, where the government then imposes cost control measures. That leads to rationing. And pretty soon, people are denied care, care is delayed when people want to go in and get a particular procedure. And because of these have been concluded that that's not a cost-effective thing to do, then some of these decisions that traditionally have been made between patients and doctors get made by the government. And so I want to read for you something that was today in the editorial in the Wall Street Journal, and I think it gets at the very heart of what I'm talking about here. But it says this: more important for the future, every Democratic version of Obamacare makes this task force an arbiter of the benefits that private insurers will be required to cover as they are converted into government contractors. What are now merely recommendations will become de facto rules. And under national health care, these kinds of cost analyses will inevitably become more common as government decides where finite tax dollars are allowed to go. In a rational system, the responsibility for health care ought to reside with patients and their doctors. James Thrall, a Harvard medical professor and chairman of the American College of Radiology, tells us that the breast cancer decision shows the dangers of medicine being reduced to, and I quote, accounting exercises subject to interpretations and underlying assumptions, end quote, and based on costs and large group averages, not individuals. He goes on to say, this Dr. Thrall, Harvard medical professor and chairman of the American College of Radiology, and I quote again, I fear that we are entering an era of deliberate decisions where we choose to trade people's lives for money, end quote. Now, what's important, I think, about that observation is that he is, I think, pointing out what a lot of people are going to be very concerned about in this country. And one of the things that I think, if you're a woman in this country, if you're a woman in my home state of South Dakota, let's say you're 42 years old, the recommendation that was made by this task force, which everybody is now dismissing and say, don't worry about it, it's not binding, under a piece of legislation like this, where you create a board that actually does have statutory powers and is enabled to make many of these decisions based upon what's cost effective. You could have someone in a state like mine, or any woman in any state in this country who is in their 40s, because they said here that the 50 should now be the baseline, or the age at which you get mammograms, you get a breast cancer screening done, that you could actually have women in this country who would be denied the opportunity to do that. And of course, we all know, everybody can name and in a personal way relate to people in this country who, by virtue of that screening process and that test, has been detected early and able to beat breast cancer, something that afflicts a great number of women across this country. Now, that's one example. I use that as an example of how this new type of government-run program might work. But there are countless other examples of the very same thing. And so, Mr. President, as we head into this debate, again, I want to remind my colleagues that this type of undertaking, reforming health care, ought to be about driving down costs. It ought to be about providing access to more Americans. It ought to be about maintaining that important relationship between a physician and their patient, and not getting to where we have the government making those decisions, where we are actually bending the cost curve up rather than driving it down. And by the way, the CBO said in response to the majority's bill that was unveiled yesterday that it actually increases costs by $160 billion. Now, to me, the fundamental goal of health care reform for most Americans, and I think most Americans, the key concern they have about health care today is its cost. Everything that we have seen so far, including this most recent version, which we're going to have at some point on the floor of the Senate, probably sometime after the Thanksgiving holiday, increases costs, drives the cost curve up. How can you possibly be in favor of something that cuts Medicare to providers and to seniors across this country, that raises taxes on small businesses, the economic engine that create jobs in this country, that raises taxes on middle-income Americans, and which also, ironically, raises the cost of health care, increases the cost of health care in this country? And again, I'm not saying this is the CBO. That has been consistent through all the bills that have been produced. It's consistent with this one as well, that the proposals and all the new provisions that would be included here, and again, $2.5 trillion 10-year fully implemented cost paid for by Medicare cuts, $500 billion in Medicare cuts, $500 billion in tax increases, and ultimately much more than that, obviously, once you get into the fully implemented time period. All that to raise health care costs for people in this country. How can we label that reform? Mr. President, I hope the American people who, as they listen to this debate, will engage, will take a hard look at this 2,074-page bill. I mean, it's going to be a lot of legislative, arcane language. We're all going to do our best to make sense out of it. But it is a massive bill, just in terms of its volume, but it also includes a massive expansion of the federal government here in Washington, D.C., at tremendous cost to the taxpayers, to Medicare beneficiaries, and in the end, doesn't do anything to drive down the cost of health care. It simply increases it and puts at risk, I would argue, many of the types of things that I just talked about with regard to breast cancer screening. When government controls, government's making decisions rather than patients and doctors, that is a world in which I don't think I want to enter, and I certainly don't think most Americans do either. Mr. President, I yield the floor.